We used a pilot hole guide in this case, and we used a ThinLayer guide. We prepared a pilot hole, and you can see how tight the space was. This poor patient was really cranking to keep his mouth open, so I could barely get in there. And then we did an angled entry, and again, even with the angled entry, it's a squeeze, and then we had him stretch so I could get in vertically. Here you get some sense of the implant placement, the implant position, from the occlusal view and from the buccal. And finally, the case, this is the implant position clinically, and here's the implant position radiographically. I think we all know that there's no way you could do this with a tube guide. So the situation is such that either you do it freehand, or in this case, I was fortunate enough to have this guide. Case 4. This is replacement of upper first and second molars in a patient with a minimal mouth opening. This case was done flapless. This patient opened about 40 millimeters, about 2.5 fingers. For vertical clearance posteriorly was about 30 millimeters. When you start running the math and you look at the drill length was 34.5. The vertical requirement in that particular handpiece was 37.1. Fortunately, maxillary teeth have a buccal cant, as mandibular teeth have a lingual cant. And so I was able to bring the handpiece a little bit to the buccal and still be on line with my trajectory to pick up the extra few millimeters I needed in order to do the case. So we made a pilot hole. I inserted at an angle as seen in the top right panel, swung vertical, and drilled the depth. And you can see the position on the right side through the occlusal view of a guide pin. I used a tissue punch, and this was a low-density case. So I enlarged the diameter of the osteotomies using an osteotome. And in the lower left panel, you can see that you can use the osteotome through the guide in order to not distort your trajectory. In the center panel, you can see the position of the osteotomies, and then the implants were inserted through the guide. Again, this is maxillary bone, very easy for a self-tapping implant to get off track. So we use the guide hole for the implant insertion. And here's the completed case, and you can see the views of the implants are in rather ideal position and made for easy restoration.
¿Lo puedo ya tirar o para querer que lo guardemos todo?
No, quítelo, ya tíralo, nada más la pura cucharilla.
If somebody's dialed into the webinar, please mute your phone so it doesn't interfere with the webinar presentation. Let me interrupt you with a few more questions, if that's okay.
Sure.
One question is if the DICOM data from the patient's CT scan needs to be converted. I can, just to address that, the Blue Sky Plan software allows the conversion to be done within the software, it's self-processing, and I'm sure that's something that Dr. Haber and his team could help with if the doctor needs help.
For sure. Actually, Michael, what we do is if we receive the DICOM data from the patient, we'll put it into Blue Sky Plan and merge the files with the stone model file. And what we send back to the doctor is a merged plan. So he can, when he plans the case, he has access to the anatomy, the gingiva of the teeth, as well as the bone data.
So you could really set everything up for the dentist and just give them the case ready for treatment planning?
Yes, pretty much. Yep. Yep.
Another question that came in connected is if a doctor has a case planned with Nobel Guide software, if you're able to help them convert the case to Blue Sky Plan and fabricate a surgical guide.
Not that I know of. Michael, you might better answer that. I don't know. I'm not aware that you can convert from one implant planning software into another.
That's correct. You cannot convert, but if the treatment plan's already done, it shouldn't be too much of a challenge to redo the plan in the Blue Sky Plan software. It should probably just take a few minutes.
I would agree with that.
Okay, those are the questions for now. I think we could continue with the webinar.
Okay, thank you. All right. The fifth case is lower left first and second molars. And in this case, we use a guide to create bleeding points by putting a perio probe through these holes. And again, it's the same principle as we described before. We're defining the trajectory sequentially instead of all at once with a tube. So you have your bleeding points here and here. We use these spear drills for our pilot holes. They're very accurate. They go right through the bleeding point. They don't slip laterally. They just lock onto wherever you put them. You can see the entry points here. We drill pilot holes. Here you can see the pilot hole, 2 millimeter diameter pilot hole. The flap has been reflected. Here are some guide pins to show you trajectories and spacing. The guide is in place. You can see that the osteotomies are in line with the guide holes. Same thing when you put pins in them. You can see how things are centered. Here are the final osteotomies. We're using the cortical drill or the countersink through the guide centered. We're placing the implant through the guide with the driver centered in the guide hole. And here you have placement of your implants. Again, ideal situation for the restorative doc. Okay. Our case number 6. These are implants into the 3, 4, 5 sites. The number 5 is an immediate implant, and we have a sinus graft in the 3, 4 sites. As you can see, we had to cut out this bridge. This was a fractured tooth over here. So here's the case. We had a drill guide with an insert in it, and we put an endo file in and created our 2 bleeding points. So these are our insertion points. We then use the guide, drill through the guide to create our pilot hole, and use subsequent drills to prepare our osteotomies. We then did an osteotome sinus graft through the ThinLayer guide. And again, the nice thing about that is that the guide maintains the trajectory even when you're using an osteotome. On the upper right panel, you can see the surgical analogs in place. In the lower right panel, you can see the as well as the sinus graft.
Ese no, obviamente, ¿verdad?
Hay que cortarlo.
¿Y ese que traía ella?
In the left panel,
excuse me, please mute your phone. It's interfering with the webinar.
Entonces, ¿eso sí lo tiro? ¿Y la corona?
Thank you, Mike. In the left panel, you can see again we're inserting the implant through the guide, and you can see on the right side the position of the implants with their healing abutments relative to the guide. Here's the final case where we have 3 implants placed. This was an immediate, and these 2, and you can see the sinus graft, and the case has been restored. Our next case is implants in the upper right. This is a patient. You can see the patient's teeth are carious. They were extracted. The sites were grafted. We placed an immediate implant in the number 5 site, and now she was ready to have implants placed in the 3 and 4 sites. We used, again, same principle. The top, the 2 points of the trajectory are defined sequentially instead of all at once with a tube. We have a pilot hole guide and we have a ThinLayer guide. So the pilot hole guide is in place. We drill through to create our pilot holes. We then, in the bottom panel, you can see we're placing a drill through the guide hole centered to depth. At this point, we used a piezo surgery to perforate the sinus floor and place a graft. And we were able to do this flapless, which is a very nice thing for the patient since the morbidity is minimal. You can see the surgical analogs in place. The two implants had different buccal lingual trajectories, and you can see that in the upper right panel. And it was a flapless case, so we used a tissue punch. What I will sometimes do in a flapless case, given the anatomy of the ridge, the buccal lingual anatomy of the ridge, the shape of the ridge, sometimes if I were to use a punch up on this case, I might have taken out a little too much of the buccal tissue. It may have been thin there. So what I'll do is I'll just make an incision and loosen that a little bit and pull it back when I place the punch. And in that way, I don't take out that attached gingiva on the buccal. And in this case, we're able to use the punch through the guide. So here you can see the final drill, which approximates the size of the guide hole on the upper left panel. And this was a low-density case. And so the osteotomies were undersized. And I'm using the guide hole to center the implant driver because the implants can find their own way on insertion. The thing you have to be careful about in cases like this is angulation by operator-induced bias. So if I am not straight going into that osteotomy, I can allow that implant to self-tap in type 3 or 4 bone at an angle. On the bottom panel, I think you can see the position of the implants. And here's the finished case. And you can see the sinus graft that we had. And so this is what the patient looked like when they went home the day of surgery. This was a flapless sinus graft. We got about 11 millimeters in height. And on the lower right panel, you can see the finished prosthetic case. And for the prosthodontist, again, this was quite a simple restoration because the implants were placed in rather ideal positions.
What information would you need to receive for a fully edentulous upper case?
A fully edentulous upper case?
Yep.
For a fully edentulous upper case, it would depend as to whether it was going to be implant-borne prosthesis or an overdenture. If it were an overdenture, we would need a model of the edentulous arch and a cone beam scan of the arch. If it were a case where it was going to be implant-supported fixed bridge work, then we would need a scan of the patient wearing the denture and a scan of the denture.
Okay. Another question that came in is essentially the dentist is receiving 2 surgical guides when they order surgical templates. Is that correct?
Yes. Each case we provide a tube guide and a thin layer guide.
Okay. I think we could proceed.
Again, our reasoning is this, is that when tube guides work, they're great. So if you have a case where you have vertical access for the tube guide, you're confident in your trajectory, you had a clean scan, then tube guides are great. It's just that you can't use tubes in a lot of places posteriorly. Or there might be other situations where you really want to be able to see what you're doing clearly. And even though you do have some visibility with the tubes that we provide, we have more visibility with the thin layer guides. It's even conceivable that someone could use, let's say on three implants placed, perhaps it's 2 bicuspids and a molar, it's possible that they would use the tube guide for the bicuspids. But because of the position of the molar and vertical clearance, they may not be able to use it on the molar. They could just slip in the thin layer guide and they're still in business.
But do you provide tube guides, or do you recommend thin layer guides in all situations?
No, we provide tube guides. We call them thin layer tube guides. You've seen some. I'll show you one in a minute. And we provide thin layer guides without tubes. We provide both in every case.